Hello, friends. Good morning from India. So, this is an interesting case of a young 42-year-old male, diabetic, hypertensive, presented with history of myocardial infarction in December 2022. And at that time, he had an acute kidney injury and creatinine went up to 3. He was stabilized on medical therapy, and then angiography was done, which showed a critical lesion in LAD and right coronary artery. And his ejection fraction has recovered over time. Possibly his artery was recanalized in time, so there was no major damage to the myocardium. So he's recovering from that, and now he came to us for the final treatment. And he's planned for a angioplasty to LAD and RCA. And Dr. Rai is planning for a no contrast, or you can say very low contrast angioplasty to save his kidneys. So right now his creatinine has improved to 1.4, but he has a tendency for this uh, rise in creatinine. So we are overcautious in giving dye. So we are planning that we'll go by the previous angiography only and will not use dye as possible as we can. And if we required, we'll use a diluted contrast, maybe 5 or 10 ml. So we'll go by the angiography. And this is the angiography image. So from the previous angiogram, which was done in December 2022. So you can see here, the left main is fine. Circumflex has lesion, which is maybe 40-50% the mid part. There is a small ramus, which is okay. Next slide. You can see there's the early diagonal, which has some lesion, maybe 50-60%, but LAD is very tight and calcified also in proximal and mid part with almost 90% lesions. And diagonal has around 70% lesion in the mid part. Next slide. So you can see the origin of the LAD is quite difficult. If we are going just by the fluoroscopic image without any dye, so we have tried to enter it with that. Next slide. You can see RC is also quite tight. Proximal part is around 50-60%, distal around 80%. So that also has to be fixed. So we are planning for a no contrast angioplasty with support of imaging, mainly IVUS, and maybe we'll try saline OCT also to see if we can see good images. So Dr. Chandra will proceed and he will guide you for next.
So thank you. And I'm Dr. Praveen Chandra, and you were listening to Dr. Nagendra Chauhan about this case in particular. And today we are going to do a ULC PCI, which is ultra low contrast PCI, because his maximum creatinine was 3.3, and now it is about 1.3, 1.4. So we don't want to give any contrast to this patient. So what we have done is we have loaded the previous angiogram on our system, and also we have first now taken. So let me show you the first image. First image today. First image, please. First image. And here you see that the hemodynamics is okay.
Problem in this. Minus. यहीं पे minus करो वहां से नहीं.
Yeah, first shot. Yeah, no, this is the previous one. Okay, first shot.
Minus.
Okay. Yeah, okay, fine. So we have not done any contrast up till now. We have taken a 7 French sheath, and this is a 7 French guiding catheter 3.5, and this is a normal, copy wire, which is all-star wire. And here you can see that we are negotiating this wire without any contrast. And based on the angiographic images, we are guiding our passage. And you can see that, it is not very difficult. If you look at the images carefully and make the whole picture in mind, then you can take the, the wire positioning. You can see that we are moving in different directions, and you can definitely, not inject anything, and the wire is in the LAD. So up till now, no injections. So the next step is to do a IVUS, and I'm going to do an IVUS, but since the IVUS was in the catheter for a while, I will just, kind of remove all the blood which was in the system. And this is with the help of a nitroglycerin injection, just to, give nitro and also wash it out. so that not too much blood should remain in the catheter for a long time. This is very important because catheter-induced thrombus formation is a common problem and should always be avoided. Although we have given 10,000 units of heparin to this patient, we will do a ACT in between. And he has been loaded with aspirin and Brilinta,
Ticagrelor,
I
yeah.
think ticagrelor.
Yeah.
So here, this is the IVUS, which is a volcano system, and I have put it in the distal segment. So now this is very important to note that we will see which is the normal segment. So here we are in the normal segment. If you can look at the IVUS images, and I will pull it back and then mark it. So here we start seeing a plaque formation. So probably this is the normal
Landing
segment
zone, yeah.
where we have to land. So this is the landing zone. And this looks like a almost 2.75 to 3 millimeters. And I'll just take a, yeah. So this is a cine image I have taken just to have an idea. So go to ariocaudal.
Log table.
Ariocaudal. Okay. Still on. Okay. Okay. So now you can see that this is the position of the catheter in the distality where we have to land the stent most likely. And now I'm going to pull it back slowly. Just store that image. Huh? So we are storing all the images so that we get a fair idea of what is our landing zone. Okay, so here the vessel is quite big and we are in the, where are we? So we are in the proximal segment. Okay. Okay. So it doesn't appear to be heavily calcific or something. And this is the left main. So you will see this is the ostium of the LAD. So more or less up to the ostium.
Yeah.
So we have to go more or less up to the ostium. The diagonal will be covered. But the diagonal ostium is okay.
Yeah. So no
Yeah.
need to protect.
And the size of the left LAD is also about 3.5 or so. Okay. So here, this is the place where is the ostium. So I can again record it. So this will give me an idea where I am. Okay. So fine, I am taking it out and we'll take a balloon to dilate this. Okay. Balloon, please.
215.
You can take a 215 or 20. So pre-dilatation. So the most important thing is that, you know, we have given no contrast up till now. And this is a 220. Yeah, 220?
Yeah.
Yeah. And show me the previous images. Previous image, please. Okay, previous. Previous image.
Yeah. Okay.
Show the previous image. Yeah.
One nahi hai.
Previous image. Yeah. So this is the proximal end. Go back. Store it. Store it and keep it there. Yeah. Go back. Yeah. So this is the distal landing zone. Okay. So now we know how exactly we are going to handle this whole situation. So keep that previous image stored, or just keep this one stored so that we go distally first.
Both are stored.
Both are stored?
Yeah.
Okay, fine. So here we are. Not a big problem.
The blockage is quite long, so we have to put a
So we are taking this, yeah. So this is a 2 into
15.
15. Go up. 1, 2, 3, 4, 5, 6, 7, 8. Deflate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. 12. 12. 14, 16. Okay, deflate. 12, 14, 16. Okay, deflate. So we are almost at the ostium. So based on the previous recorded, positioning, go up 2, 4, 6, 8, 10, 12, 14, 16, 18. Okay, deflate. So now this is the good movement of the balloon, and we have done the pre-dilatation. Now we have to take the stent. So we have to take a long stent, and so we have the choices. The choices are, we can take a 348 or take a 360.
348 may be sufficient because this is 32 by marker, if we can
So
see.
by marker, and then
32 plus maybe 20 more.
20. So 50 is minimum. 50, I think 48 or 50 maybe, or 60 will have more, we'll have more, margin. So otherwise there will be a chance that we have to do a
second stent.
So we'll take a 60, 3.5 into 3 or 3.5, 2.5. So we have a tapered stent.
3.5, 360.
Yeah, so we have a 3.5, 360, which we are going to take, and we'll see how it goes. Okay, so this will avoid two things. One, two stents, then overlapping, etc. And the second is that, of course, it will bring down the cost factor. So this is a BioMine 3.5, 360. At this time, when we will be at the ostium, we will give some dye, which is 2 ml of contrast. That's all. So here we are taking a 3.5, 360. And as we saw, that we'll have to do it from the ostium. Okay. So here you can see there is some
guide support is required.
Issue of the.
So there's one point where there's some calcium chunk, otherwise there was no major calcium. So I think because of the long lesion, this is creating some problem, but I think
It's okay.
Able to negotiate it.
Okay, we can pull it a little bit back.
Yeah. Okay. From the previous image.
Okay, let's go to the iliocaudal, please. Iliocaudal. I can bring it a little bit back.
Yeah.
No, I think you don't inject. I'll bring it a little bit back, because I can also see that little calcium there. Yeah. So this will give us some idea. So show me the first shot, please.
From
angiogram. From the angio. Show the angio in the iliocaudal position. Yes.
Next. Yeah.
So just very carefully have a look, and we can identify some markers. So we'll take the same view and see where we are. Okay.
I think we are almost there. Maybe we have to come slightly proximal. That's all. Maybe slightly more. Now it is good, I think.
Okay, we'll take a quick, just 1 ml. Yeah, more or less okay. Okay, so we have just given 1 ml of 2 ml of contrast, and show me the last shot.
Minus.
Previous. Okay. We can bring it a little bit proximal, little bit. Although there is some enough space. I think that should be fine. Take a little contrast, 1 ml. Yeah, that's fine. Perfect. Okay.
We
So
are
we
quite
are
away
okay.
from the main and
Uh,
just 1 mm inside, so I think it's okay because
Okay. Show me. Yeah, we are fine. I think we're fine. Okay. We are fine.
yeah.
All right. Okay. So go up. 1, 2, 3, 4, 5, 6. Okay. Epicranial. Okay. 6, 7, 8.
Some deep
Okay.
calcium is
Yeah.
wow.
9. Deflate. Okay. So we will deflate a little bit. Let
3.5
the
balloon.
artery
3.5
breathe.
balloon.
3.5. We go up. 1, 2, 3, 4, 5, 6, 7, 8, 9. Sometimes if you do the second inflation, it becomes a little bit better. Redistribution of forces, deflate. And then we will take a 3.5 now. 3.5.
Approximately.
Because distally
This
it
is
looks
very well
okay.
expanded.
Yeah.
3.5, 12 to 12.
3.5, 12. So here we are. And so the ECG. So the important things are when we are doing ultra low contrast PCI, keep looking at the ECG, patient symptoms. All these are indicators that yes, everything is okay.
Yeah.
If there is a
Because
side branch occlusion,
if there's no
or
flow, slow flow, there is no other way to diagnose
yes,
because we are not giving any dye. The only way to diagnose is by symptoms or by ECG changes.
by and the
Yeah,
hemodynamic.
hemodynamics. Yeah.
Okay.
So right now, very preserved hemodynamics, 160 by 40 blood pressure.
Everything has remained stable.
Yeah.
So this is a clear indicator that we are fine.
Are you?
Caudal. Okay. So this is fantastic. And we can do this thing, stent boost.
Stent
So you can
enhancement,
look
yeah.
at the stent boost enhancement, which is on the volcano. Now this system is a very interesting one, which is a offline system, which is continuous. And I can see it very clearly without doing any digital imaging. So we can see that it is very clear. Can somebody focus on this one? This, okay, go up. 2, 4, 6, 8, 10, 12, 14, 16, 16, 18, 18, okay, 20. Okay, that's nice.
Looking good.
So the expansion looks good. Deflate, please. Deflate. Okay. So now I can again see on the, now this looks that the stent is fully
Yeah, it's
expanded
here.
and we can go distally. Okay.
Yeah.
So I'll move distally.
There's one more
Go
point
up.
of
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16. Deflate.
20 ml your love.
Okay. Okay, now we are in this segment. You can see that the stent is not so well expanded here.
Your lock.
Go up. 2, 4, 6, 8, 10, 12. Show this picture. 12, 14. Okay. Fine.
Yeah,
It's gone.
it's
It's gone. Deflate. Epicranial. Continuously running. I'll go a little bit distal. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay. We'll give it some time. 14. Yes. Better. Deflate. Okay. Deflated. Okay. Okay, go up 2, 4, 6, 8, 10, 12, 14. Okay, 16. Fantastic. Deflate. Okay. Now a little bit back here. You can see very clearly. Go up 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. Deflate.
That is good.
Now it is good. So everything up till now seems all right. And so I'll take this out. So what do you want to do? IVUS or OCT?
You can do
First,
OCT.
since we have the IVUS,
We
we
can
can
do
do IVUS and then reconfirm with the saline OCT. That's it. And then in case we see any further expansion to be done, we can do it. So we are now doing a IVUS. Okay.
That's okay. All stars. Atraumatic.
Use it for the RCA also. So this is the volcano IVUS, which we have again taken same.
So we have more distal part. Vessel is looking quite good without any plaque. Now Lufthansa is coming proximal. There is no lesion here. And coming proximal. Now you can see the stent ended at a normal segment with very well expanded stent. So you can see the good expansion up to this point. There is some elasticity, but I think that's because of fibrotic lesion. But the vessel size is lumen is quite good. Here again, the vessel luminal area is quite good. There is some fibrous plaque on 11 o'clock position. And now we have, I think we have catched the ostium perfectly.
Yes,
Yeah.
perfect. I think it's
So
perfect.
just at the ostium we have landed. So it's good.
So can you just review it? So the distal edge is looking fine. The proximal edge is also fine. Okay. Yeah, perfect. So according to IVUS, imaging, everything seems good. Santosh, this paddle is creating a problem. तो ठीक कर लो. So this was a 3.5 into 3, and we dilated it with a 3.5 proximal and the mid and up to the almost distal segment. Yeah. Now bring it forward. Okay. Okay. So this is our OCT. Bring it forward. Bring it forward. Bring it forward. Okay. So, okay. So what is the settings? Settings are survey 75 and the catheter looks good. So you are going to take this is a 20 ml syringe with saline. Okay. Fill it, first fill it. Fill it. Fill. Okay, take in some more. Yeah. The only thing is sometimes, because of the cold saline, patients can have usko charge and.
Okay, I'm ready.
Okay. So we are taking this. Are you ready? Okay, fine.
You can see the some part, not the complete.
Yeah. So distally, it is very clear that there is no dissection, very good apposition. and stent expansion looks good. So this is one thing which we have confirmed that the distal segment is absolutely fine. And we can do one more shot, but I think it's not necessary, and we are fine. So this is pure saline only, and everything is okay. So we'll take it out. I'm not
Yeah.
taking any shot. Okay?
Yeah.
Yeah. So no shot at all. This is almost zero contrast angioplasty. So give me the wire, please. So now this LED has been done, and with a long stent, everything is okay. And now I'm taking the right catheter, RCA. RCA, please.
RCA guiding.
So this is just to emphasize that even in multi-vessel PCI, we can do this, and also send a ACT. Let me have the ACT syringe, please. ACT.
One more wire, BMW.
ACT. No, give me a syringe. Okay. So normally in a slight, 2-vessel procedure or a 3-vessel procedure, it is always a good idea to do a ACT in between. There is no harm. And that's it. Okay. So this is a RCA 6 French.
6 French.
And again, we will engage without any contrast. Okay. So can we now have a look at the RCA injection which was done in the past?
From outside. Show RC from outside.
Okay.
Flush. So RC has 2 lesions. One is in the proximal part, around 60-70% we confirm with IVUS, and there's a distal lesion which is significant, we definitely we have to fix. So either we can use one small stent in the distal part, and if required, another small stent in the proximal part.
Okay. So this is the plan. And we should also try to see if there is any calcium which is visible in a ultra low contrast PCI. We should take the help of these landmarks on a normal angiogram. And here we see that there is some calcium which is at the bifurcation. So everything has to be before that. Okay. So this is the normal BMW wire which we are taking, and yeah, let it go. Let us know the ACT as soon as it is ready. Okay. Yeah. Okay. Yeah. So here I am, and now I will engage the RC. So this is, yeah. So this looks engaged. The pressure is okay. So we are fine. Now I will try to negotiate the wire.
Very small branch.
In the small branch.
Yeah.
Okay. Okay. So we are in a reasonable branch. And at this stage, we can even do a dilatation in the distal part, or we can do a IVUS first. So since it is not very tight, so we will try to do with the IVUS first and see the plan, the stenting size, length, and location. Okay. So we are in the proximal zone. Yeah. Yeah, here, this lesion looks quite significant, at least at this point. Okay, I'll go distally first. Okay. So this is in the distal segment. Let's do a pullback. Yeah, this is the tight portion. So let me just locate this also. This is the locator. Okay. So this is how we have to see the distal positioning of the distal stent. And this is the proximal. So you can see that this is the proximal landing zone. So this means it is a small stent, 15, 16 millimeters. And then there is some disease here,
I think we can
not
leave
to
this.
be done. We can leave all that. And proximally, we are coming in the proximal segment.
So this is the tight
Yeah,
part.
this is the tight portion. So this is, you can see. Okay. So I will just now see the distal landing zone of the proximal stent. Okay.
So this
So
is
here it is. And then now this is the proximal and this is the proximal landing zone. So this will
again
be
a small stent.
very small stent. Okay. Fine. So let's have the first stent,
Yeah, there's no,
which is a
no
3.5.
calcium. So
We can take a balloon first, maybe a 2 millimeter balloon. 2. Yeah, 2.5, whatever we have.
so we have two.
So what is the size of the vessel distally? Distal. 3.5.
Yeah, measure here.
Almost like a 4.
So 3.5 and 7.5. So 3.5 stent is required. The vessel size is 3.5/4, so maybe 3.75, and this is the proximal
Okay.
landing zone. Measure here also.
Check. No, not check. Okay, so show me the previous shot. Previous one. Previous shot. Previous.
Inside.
Now this is the location of the distal landing zone. And according to this, looks like a 12 to 15 millimeter stent.
Yeah.
And I'm going to just exactly put it there.
Yeah, I think
It's
this is
okay.
there.
Fine.
Yeah.
Go up 2, 4, 6, 8, 10, 12, 14, 16,
So 3.5, 15
18.
stent.
Deflect. 3.5, 16. 3.5, 16 का दे दो.
16.
16. Okay. Not 4.
Oh, so it's
Better to take
the
a
proximal
3.5.
landing zone is again 3.75. So you have to
Okay,
be
so
one
we'll
stage.
take a 3.5. Okay. 3.5, 15, you can give a cruise.
So ACT is 355, so we are comfortable.
It's good. It's good. And the ECG is okay. The hemodynamics is okay. Everything is okay. Show me the angio, please. Show me the angio. Angio picture of the RCA from the angiography. So we always keep looking at the angiographic pictures to, not forget the anatomy. Okay. So this is how it looks. And we can even take a slightly longer stent if you want. According to this, we can take a 22 or 23.
23 is okay.
23
3.5.
expedition. 3.5, 23 expedition. 3.5, 23 expedition. Okay.
Yeah.
Yeah. So this is a Zines Alpine. Yeah.
Yeah.
3.5, 23. Okay. Yeah. So this is, high pressure device. We can go up to 12 14 atmospheres without too much of increase in size. And we will take this. And this is the only time we are going to inject a little bit, 1 ml, not now. Okay. Yeah. Can you store it? Store the images. Back one. Show the stored image. Show the stored image. Back. Yeah, that's one. Yeah, okay. So you can see that we are almost matching in this position with the distal edge of the that ultrasound, IVUS detector. Okay, and we can now give you a quick check. Check, please. Yeah, perfect. You can see that, if you make a good image, you will be able to do that without any problems. Go up, please.
1, 2,
1,
3,
2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So we are exactly located, and 12 is fine. Okay. Deflate. So we do it for about 30 seconds because, there are some few studies which show that 10-second is, less. 30-second expansion is better than 10 seconds. Okay, deflate, please. Okay. And if we can see on the, again,
well
the
expanded stand.
stent boost, it looks good.
Yeah.
So we are done. And now we take the second stent in the proximal. Proximal stent, please. How
Again,
much is the size? 3.5 and 4.
3.5 is
Show me
fine.
the angiogram. I think 3.5 should be good.
Yeah.
The first angiogram again. Again, we will see the angiogram. So
3.5, 15.
show the
12
angio,
point.
please. 12 is also fine. 15
Second
or
now
12. Yeah.
3.5, 15. Huh?
Okay. Yeah. So here we can take a 15, 3.5, 15, or even 3.5, 15 should be
I
good.
think it's
Yeah.
cool.
In case required, we can go with a 4
Yeah.
if it is needed. So again, we will do an IVUS soon after this implantation. Then we will do the post dilatations. So why we are doing the second stent now and not doing the post dilatation? Because in case we needed a post dilatation to both, then and with a 4 we can do with one balloon or in one shot. Otherwise, we'll have to go 2 times. Just trying to save some extra runs. Just a minute. Now we can take a shot. Stop.
You can go forward.
Can go a little forward. Yeah. Okay.
Maybe more.
Maybe more. Check, please. Yeah, fine. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9. Store it. 10, 12. Okay. So this looks again expanded well. 12, 14. Deflate. So this is fine. Yeah. Now let us do an IVUS.
You want IVUS and OCT? RCA, we can do an OCT also.
Yeah, we will do OCT also.
Okay.
But first IVUS and then post dilatation if needed, and then final OCT. So no contrast still.
Yeah.
Okay, so the ECG is okay, and the hemodynamics okay, everything okay. Yeah, so now we are in the distal part, just distal to the stent, so you can tell what we see.
So you can see the vessel is quite normal at this point. The stent is very well opposed. Maybe we can go 1 mm post dilatation more. So we can go 3.5 high pressure, and here also it is not fully dilated. There is some under expansion. There is no malapposition. So the proximal and distal edges are looking fine. So I think we can use same 3.5 balloon at high pressures, or because 4 will be slightly bigger for this. Yeah,
This is perfect. Yeah,
yeah, this is perfect. So
the
proximal
proximal
and
edge is
distal.
perfect.
Yeah.
we can now see the second stent.
Again, there is no dissection, the distal edge, and the position is perfect. We are landed in some plaque, so it's acceptable because the expansion is good. The lumen area is quite good. So
This
expansion
is
is
better
yeah,
actually.
yeah.
It's quite good. So we can do with
Do
the
some
same
post
3.5
yeah,
balloon.
yeah.
That's all. So overall looks almost done. And this is a 3.5.
3.5, yeah.
So there is a 3.5 NC track, and okay.
Yes,
Okay.
quite good.
Okay.
Yeah.
So we are in good position. Go up, please. 2, 4, 6, 8, 10, 12, 14. Okay, deflate. So this is the the stent
Distal edge,
boost,
yeah.
which is an online stent boost, and very nice. And we don't need to do repeated shoots with this. Go up 2, 4, 6, 8, 10, 12, 14, 16. Okay, deflate. Fine. I think we are done. Okay.
Yeah.
So we will do a OCT finally, and that's it. So this is
I'm sucking the
same,
contrast from the right.
same.
Yeah.
So that it doesn't go inside. Yeah. Yeah, we need a syringe, 20 ml.
20 minutes, right? Line.
Bring it forward. OCT, please. Okay. Okay. Can you bring forward? Bring forward, please. Okay. You have to fill it.
करता हूँ मैं सर. I will
कर
do
रहे
it.
कर रहे. So
First
you
I'll
need
flush the lumen.
so
of the
flushing the
catheter.
lumen. Yeah. Again flush more. Oh, blood again. Okay. Okay, fine. So we'll flush the side lumen.
Now we'll do the side port.
Here it is. Side port. Okay. 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 Perfect.
So I'm ready.
Just a minute. Okay, you are ready? Okay, fine. Okay.
It was slightly small.
So you can see that.
We may have to use one more run. So stent is
Yeah,
looking
that's
fine.
nice. Stent looks good.
We may have to use one more
One
run for the
more, one
proximal
more,
stent because it was quite long, so
uh.
it has not covered both the stents.
So we can see that very clearly. So the proximal stent we will do. The distal stent looks okay. Yeah. So I will bring it a little bit back in this position. That's all. And once you are ready, you'll tell us.
Yeah, I'm ready.
You are ready?
Yeah.
Inject. Perfect. That's very nice.
Some under expansion. We may have to use a 4 balloon.
So you see how clean the image is. The distal is perfect. The stent is well opposed, expanded. Proximally, we might have to do a little bit.
Yeah.
So show the size. Okay. Give us a balloon, please. We didn't do that post here. What is the size? 3.8. Yeah, so it's better to take a 4 with the low pressure will be fine. Give us a 4 millimeter balloon. 4.
So for RCA,
The distal edge is fine.
For RCA, there is no other branch. It's very easy to do saline OCT, but for it is much more difficult. Yeah.
Yeah. 410. So we are taking a 410 balloon. This is a 15 millimeter stent. So we are fine. The distal edge is absolutely fine. And you can see that we will do this and it'll be fine.
All cards are patent. RCA is patent. Native DVD, same.
Nothing is minute.
No. After
Okay. Cine boost, it's okay. Yeah. So you can see now very clearly that we are absolutely perfect
At the edge,
position.
yeah.
And go up, please. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Sufficient.
I think that should be sufficient. Okay.
We can do some in middle because there
Some in the
are some
middle also.
expansion.
Deflate, deflate.
There are some
So I'll move it a little bit
malabsorption and some
inside.
under expansion, so we have to fix both.
We can do that. Yeah. It's okay. Yeah. I'll
See
pull back a
outside,
little
yeah.
bit. Yeah.
Pull back, yeah.
Okay.
Just to the edge,
Go up.
yeah.
1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. Deflate. So you can see that, you don't need to do injections to see where you are. You should always use this stent boost, which is now available in various ways. And this is the one, we have one in the device, this cath lab itself, which is the Siemens. And this is the Volcano. This is the system, I think, which is known as the co-registration system. And we can even do a co-registration, but for that we need to do injections. So we need to do that.
So
And
in
I'll
one,
do
we can one more OCT.
one more OCT we
Proximal?
can do, no problem. Just to demonstrate that yes, everything is okay. What we did is done something. So contrast-induced nephropathy is a real problem.
This is I-was, I have given you.
What is I-was? Okay. Then give me the OCT, please. So we have to be careful. We take all precautions and give minimum. So the only thing which can prevent contrast-induced nephropathy is hydration and less contrast or no contrast. So this is like doing angioplasty with no contrast.
Yeah.
So you can see it is not difficult. It is absolutely doable without contrast. The only thing is that mindset has to come in a little bit. Okay. So I'll put it a little bit back. Okay, fine. We have
Slightly
well,
more.
slightly more. Okay.
Because this will
Okay.
take some time to
Okay.
clear,
Okay.
so we need some
Okay.
extra knowledge.
Okay. Fine.
Yeah.
Nahi?
Guide has come back.
Okay. The guide has come back.
Yeah.
No, it's okay. Looks all right.
Not as
I
good
mean-
as we wanted.
Yeah, so we can do one more.
Yeah.
Yeah, I'm ready.
More and so because
Oh.
it takes some time to come. Yeah,
Okay.
now it's okay. Yeah.
Okay. Inject full. Perfect. Very nice. Show it on this big screen. So the distal edge is absolutely clean.
Yeah, very well
And,
dilated now.
Very well dilated. And the
As soon
proximal
as
stent
it's
is also
very
very well
closed, no
approached now.
dissection. Yeah, no
No red these things. Okay, so we are fine. This is absolutely done. And so we don't need to inject anymore.
we don't have
So we did only 3 ml contrast in this entire procedure, and that's the end of the story. Okay.
Yeah.
So I'll take this out, and that's all. So no injections, only 3 ml of contrast, and this is what we call as almost no contrast angioplasty, and or you can call it ultra low contrast like ULC PCI. And so basically we actually guided by the GFR, although in this patient the GFR was about 60 now, but it had gone down. So this is why we thought that we will prevent as much as possible. And you can see that we can do that even if it is a 2-vessel angioplasty.
Yeah.
So you are happy with this OCT pictures?
OCT
Show
pictures
the
are really
OCT
good for
picture.
RCA. So we can see the distal and proximal edges are fine. There's no dissection. Expansion is very good.
Mm. And the IVUS was also okay.
So
Okay.
this is always the plan that we use IVUS for assessment of vessel, stent sizing and all, because OCT sometimes give you undersizing. And for final completion of angioplasty for stent expansion, we use OCT. The best combination of both the imaging techniques. Dr. Chandra has shown the way you should do it in low contrast angioplasty. Thank you.
Okay. So thank you very much. We'll meet again at 4:30 with the PAVL. It's a mitral PVL closure case. So hopefully it will be exciting too. Thank you very much. Thank you.
Thank you.